To join Carlson for part 1 of a 3-part webcast series, PARP inhibitors in ovarian cancer, current advances and future directions in the treatment paradigm. This is an educational series supported by an independent educational grant from GlaxoSmithKline and presented by Creative Educational Concepts. To claim credit for this webcast, Digging Deep into the Genome, What Genetic Testing Can and Can't Tell Us About Ovarian Cancer. Be sure to complete the post-test questions and the evaluation. This webcast is moderated by Dr. Beth Carlin, Professor and Vice Chair of Women's Health Research, Department of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA. We will begin with a short didactic presentation by Dr. Joseph Carlson, Professor of Clinical Pathology, USC Keck School of Medicine. After Dr. Carlson's slide presentation, we will conclude the webcast with an insightful discussion between Drs. Carlin and Carlson on genetic testing in ovarian cancer. Thank you for your participation.
Great, so let's jump into our first important medical moment today. Digging deep into the genome, what genetic testing can and can't tell us about ovarian cancer. To discuss this with us today, we're honored to have Dr. Joseph Carlson, who is the Professor of Clinical Pathology in the Department of Pathology at USC Keck School of Medicine at the University of Southern California. Dr. Carlson also leads the Gynecologic Pathology Unit at USC, and he's a friend and a colleague. The learning objectives for this first medical moment are again to discuss the recent updates in the national recommendations on genetic testing and counseling and the appropriate identification of patients who should receive this testing. We'll next discuss and examine the best practices in the selection of which biomarkers to test for and the use of various testing panels and the appropriate interpretation of those results. So with those lofty goals, I will hand this over to my friend and colleague, Dr. Carlson.
Thank you so much, Dr. Carlin. It's a real pleasure to be here and discuss this important topic. So much has happened over the last decade regarding epithelial ovarian cancer, and there's a few very important take-home messages for those participating in this learning activity that I'd like to emphasize. First and foremost, we now understand that epithelial ovarian cancer truly consists of 5 very distinct diseases. I think everyone is aware of this more and more, but it's very important, especially as we consider the role of PARP inhibitors and the genetic underpinnings of PARP therapy. These 5 subtypes, of course, are high-grade serous carcinoma, the most common, characterized by these extremely frequent mutations in the TP53 gene. They have approximately 43.8%, so that's from one article, ranges on how you determine it, but anywhere from 30 to 50% of homologous recombination deficiency in that last column. The other subtypes, low-grade serous carcinoma, clear cell carcinoma, endometrioid, and mucinous subtypes have other molecular characteristics such as BRAF, KRAS, deletions or changes in ARID1A and PIK3CA, as well as KRAS in the mucinous tumors, and varying levels of homologous recombination deficiency, which then impacts the role of PARP inhibitors in their therapy, as we'll discuss. Some of the recent developments, which are then described in the NCCN guidelines, are that, as has been established for a number of years, all women with ovarian cancer should be referred to clinical genetics for germline testing for, at a minimum, BRCA1 and 2 pathogenic variants or likely pathogenic variants, as well as other cancer susceptibility genes. Patients where a germline pathogenic or likely pathogenic variant has been identified in BRCA1 or 2, they should be offered PARP inhibitor therapy. They're the ones who will find some of the greatest benefit of this therapy. In patients without a germline BRCA1 or 2 pathogenic or likely pathogenic variant, or where the status is unknown, focus turns to evaluating the tumor with somatic testing. The tumor should be evaluated for, at a minimum, homologous recombination deficiency, because this can guide further treatment options. To discuss homologous recombination deficiency, DNA repair is a cellular process. It's a process which cells, including tumor cells, utilize in order to survive and proliferate. There's many different methods of repair that cells use when their DNA is damaged. And homologous recombination is the one which is used to repair double-strand breaks. When a tumor cell is homologous recombination proficient, it's using the sister chromatid in order to perform a high-fidelity repair of these double-strand breaks. So it's essentially copying its homework off the other sister chromatid, which is still intact, in order to perform a very high-quality, high-fidelity repair of these double-strand breaks. If the tumor is HR deficient, this means that these double-strand breaks, which must be repaired, they're being repaired by alternative, more error-prone methods. These methods include things like non-homologous end joining, microhomology-mediated end joining, and single-strand annealing. What this means in practice is that tumor cells, especially high-grade serous carcinoma, which is the one which has the highest quantity of tumor cases that are homologous recombination deficient, they're lacking this homologous recombination. They're relying on these other pathways to repair their DNA. So I kind of like to think of this as a person standing on two legs. High-grade serous carcinomas that are homologous recombination deficient, one of their legs is gone. They're standing on only one, and that one leg represents these other DNA repair mechanisms. What PARP inhibitors allow us to do is knock that second leg out from under the tumor cell, causing it to die in a process called synthetic lethality. So PARP is the enzyme involved in these secondary repair mechanisms, and the PARP inhibitor is basically blocking the tumor cell from being able to repair these double-strand breaks. This leads to an increase in double-strand breaks, which in the HRR deficient cell, as we see in this slide, leads to accumulation of DNA damage and cell death, as opposed to in a cell which is homologous recombination intact. These cells can still repair their double-strand breaks, and so these cells survive. So homologous recombination deficiency can be caused by a number of mechanisms. We've already mentioned BRCA1 and 2. They are really central genes and central players in the mechanisms of homologous recombination deficiency. So pathologic or likely pathologic variants in BRCA1 or 2 really lie at the center of our understanding of homologous recombination deficiency. However, as always in cellular processes, there's a number of other genes and the proteins that they produce involved in these mechanisms. Damage to these other genes can also cause loss of homologous recombination. It's maybe not a total loss, and so that's where it can become complex when you start to have these secondary genes. Another mechanism of homologous recombination deficiency is epigenetic silencing, or essentially promoter methylation. What this is doing is preventing the intact gene from being expressed. So it's a way of losing the functional protein, but the gene is genetically intact, one could say. There are, in addition to looking for and detecting HRD, as we can see in the bottom part of the slide, looking at the BRCA1 and 2 genes, looking at these other more secondary genes in a gene panel, but there's also something called genomic scar assays. These are essentially looking at other secondary ways that homologous recombination deficiency impacts the genome, because HRD will cause things like loss of heterozygosity, telomeric allelic imbalance, as well as large-scale state transitions. These are more complex genomic rearrangements and changes which can be detected, which also indicate homologous recombination deficiency. So, to the question of when to test and when to treat. When a diagnosis of ovarian cancer is confirmed by pathology, all patients should receive genetic testing and genetic counseling, as we've already mentioned. If a germline BRCA1 or 2 pathogenic or likely pathogenic variant is present, they are likely to respond to PARP inhibitors. And so we move forward to this group of drugs in the middle of the slide, the PARP inhibitors. If the tumor tissue, so now somatic testing shows HR deficiency, particularly then in patients where they do not carry a BRCA1 or 2 variant, or where they haven't been germline tested. So we've moved to somatic testing. If the tumor tissue shows HR deficiency, they also may receive a benefit from PARP inhibitors. And so we see on the right-hand side of the slide a summary of this take-home message, where if they're germline negative, they're less likely to respond to PARP inhibitors, and you should consider tumor tissue testing. And if they're tumor tissue HR proficient, they are less likely overall to respond to PARP inhibitors. And just to reiterate, all women with the diagnosis of ovarian cancer should have genetic counseling and testing. The NCCN guidelines in general discuss 3 different types of testing. They mention germline and somatic BRCA1 and 2 status testing. They mention HR testing. And then they mention a more general catch-all molecular tumor testing, which is a broad term where this testing should include, but not be limited to, perhaps BRCA1 and 2, HR status, as well as other genetic changes of interest, such as microsatellite instability, tumor mutational burden, NTRK fusions and rearrangements. And all of this tumor testing goes under the umbrella of what the FDA calls companion diagnostic devices. So these are tests that have a corresponding therapeutic product, as well as FDA guidance regarding nucleic acid-based tests. So these are tests that look for variations in the sequence structure or expression of DNA or RNA to diagnose diseases. So together, reviewing some of the FDA guidance or the tests that have been approved, here we see a list of the companion diagnostics along with their corresponding therapy. And we can see that there are several testing options. I have focused in this slide on somatic testing because that's really the focus of our discussion today. That is to say, tumor testing. And we have options from Myriad, the Myriad My Choice. Foundation Medicine has some options. And then in the tumor profiling space, there are such tests as Caris Molecular Intelligence and Tempus. And there's even one liquid biopsy test offered by Foundation Medicine called the Foundation One Liquid CDX test. So these are all options. And the exact choice of these tests can depend on what is known about the patient in terms of their germline status or possibly other somatic tests that have already been performed, and what exactly are the considerations that the clinician and the clinical team is considering in terms of treatment. So some of the take-homes from my slides today. First of all, of course, it's a very exciting time for ovarian cancer. Ovarian cancer has truly entered the molecular area. The choice of test and timing, it does vary widely. Some institutions use upfront broad testing. Others use a more step-by-step selective testing. Both can be appropriate depending on the practice setting. BRCA1 and 2, the identification of pathogenic and likely pathogenic variants, these are the clearest biomarkers for PARP inhibitor therapy. But of course, as we mentioned, there's other secondary genes which can contribute to HRD and can also indicate response to PARP inhibitor therapy. HR status, as detected by things like genomic scar, can also provide valuable information to the clinicians and should be considered in the non-BRCA1 and 2L likely pathogenic and pathogenic variant tumors. Finally, there is a sentence in the NCCN guidelines that says more comprehensive testing may be particularly important in less common histologies with limited approved therapeutic options. There's still a lot of discussion about the level of evidence for this statement about more comprehensive testing, and the role of more comprehensive testing really depends on the, I guess, individual practice setting. So thank you very much.
Dr. Carlson, thank you so much for that fantastic presentation and discussion of this quickly evolving field. And as you say, I think we can all celebrate that ovarian cancer has entered this molecular era, because it does seem to be translating into improved survival and quality of life. So I think the only point I would underline is that your discussion in our use of PARP inhibitors are after the patient completes their frontline chemotherapy, that's in the maintenance setting. But the underpinnings and the discussion of PARP inhibitors, I agree with you, should start much, much earlier. You clearly let us know who are the best candidates for PARP inhibitor therapy. So if someone has somatic testing, by whichever means you outlined, and they are HRD positive, why would they still need to have germline testing? How does that enhance the situation for them?
Yeah, so that's a great question, Dr. Carlin. So, tumor testing will tell us, of course, about the tumor and how the tumor might respond to these various therapies, but it's really not telling us anything about the patient's germline. It's not telling us about their hereditary risk. That question is still unanswered by somatic testing. So all patients need to have genetic counseling. That can impact the patient by, of course, allowing them to have other perhaps risk reducing or risk modifying strategies that genetic counselors are experts in, and can also open up for the opportunity of things like cascade testing of families and things like that. And I mean, I'm not a geneticist, so that's beyond my competence, but certainly it's critical for ovarian cancer patients. And so that's a very important point you bring up. Identifying somatic changes in the tumor, critically important, but it does not remove the need to send the patient for genetic counseling and a genetic evaluation, I would say.
Yeah, no, I thank you for highlighting that, because they, as you said, different processes, both from a laboratory base and the way the DNA is analyzed and the genetics, but the risks for additional cancers, and then the important opportunity to test family members and then prevent cancers that way too. So I think something else not to be forgotten. When you talked at the end a bit about the larger panels, in someone who has HRD detected, and perhaps, what else would that additional panel testing give? Are there other targets? Are there other trials? When you do a full, molecular profile of a tumor, what other opportunities does that add to us beyond HRD?
Yeah, I mean, so those panels include a range of, potential targets. They do typically include MSI. So in there, one thinks of immunotherapies. They typically do include NTRK, because there's targeted therapy for that rearrangement. They, of course, when they design these panels, they sort of pack them in or build them to include as many potential targets as possible. I think the one perhaps caution there is that, every patient's journey through their cancer therapy is a process with many steps and discussions. And, a patient, for example, a patient where one has already identified HRD, I can suspect that the next few stages of their therapy and prognosis are sort of already determined by the HRD. It may be that one is already planning to then offer them a PARP inhibitor. And in that case, identifying MSI or these other changes, that may not be relevant at this point in time for that patient. And so that might be an argument to wait for the broad panel, because it may not really influence the sort of treatment decisions that you yourself or others in your team are making at that point in time. That would be the one sort of caveat to, the role of this broad panel testing, that it really does all depend on the clinical situation, the judgment of the team, and where that patient is in their journey, I would say.
No, very great clinical insights. I think, some patients are always thinking steps ahead of what about a clinical trial, and if I have this alteration, would that be a possibility? And also, some of them want to have all the information up front, but I agree with you that the most actionable information right after, in that first line setting is whether or not how likely they are to have a prolonged remission, possibly cure even with the PARP inhibitor. So I think that that's fantastic. So would you consider a PARP inhibitor a targeted therapy?
I do. I do. I'm not aware of a, sort of strict consensus definition of what's targeted, what's not targeted therapy. But to me, of course, it sort of evolved from a different angle than what we typically think of as targeted therapy, in the sense that, the original targeted therapy that I remember was the EGFR receptor in lung cancer, right? And so you identified that in the tumor cells. PARP inhibitors, of course, came from an understanding of HRD and the hereditary situation. And so it sort of came from the understanding of the patients who are hereditary carriers of BRCA1 and 2 likely pathogenic variants. But in the same sense, as we're discovering more and more, if the tumor has that modification with or without the patient, it's a target. Yeah. So to me, it is still, I kind of group it into targeted therapies. So
I would agree with you wholeheartedly. I think the exciting avenue that PARP inhibitors have opened up is this idea of synthetic lethality, that it doesn't just have to be the EGFR that you hit directly on the head, but you can ambush it.
Yes.
With the synthetic lethality process. And it is a very exciting time as we see the application of more and more therapies that could be applicable for women with ovarian cancer. And while we spoke today predominantly about high-grade serous tumors, really the testing can be done for all the subtypes, because every now and then you do see endometrioid, or you do see a clear cell where a PARP inhibitor may have some benefit and can really translate that to improve quality of life for the patient as well.
That's a very important point. And I think, as a pathologist, I'm someone I've been lucky enough to see this evolution of these 5 different subtypes and improving our understanding. And of course, in pathology groups, there's been discussion about, should there be, subtype-based testing, because BRCA1 and 2 and HRD are so much more common in the high-grade serous tumors. But it is a very important point that hereditary carriers, or BRCA1 and 2, it can be found in any tumor subtype. It's just a question of how common or how rare. We don't really know enough. Our histology is good up to a point, but depending on, what's being considered clinically in the situation, it could still be motivated, of course, to send it in any subtype.
But I think having expert pathologists is so important more and more today, especially in GYN pathology, to differentiate the subtypes as we think about new clinical trials being put forth just in a specific subtype, recognizing that as you went through, the molecular phenotype is different, the risk factors are different, the response to chemotherapy is different, just like PARP inhibitors. So having good partnerships and communication with expert GYN pathologists is really key to patient care and to the effectiveness of our therapies. So thank you.
We do our best, but we're happy to be part of the team. So
absolutely. So with that, I will thank you for joining us for this first medical moment, and please stay tuned. There's more to come. Thank you.
Thank you very much.
Thank you again for joining us for this educational webcast focused on genetic testing in ovarian cancer. To claim credit for this webcast, be sure and complete the post-test and the evaluation. Also, be sure to access the other webcasts in this series, Webcast 2, Appraising Current Safety and Efficacy Data for PARP Inhibitors in Ovarian Cancer, Best Practices in Treatment and Adverse Event Management, and Webcast 3, Recognizing and Addressing the Elephant in the Room, Multidisciplinary Strategies to Mitigate Disparities in Ovarian Cancer Patients.